Okay, well, good afternoon, everyone, or good morning, everyone, and welcome to teaching today. Today, I wanted to talk about a different sort of infection, and there's several reasons. It's leptospirosis, and it is an emerging infection in Pacific Island nations, and it's well established all throughout Southeast Asia. I want to talk about it as a commonly occurring infection that is rarely diagnosed, and also because it's a zoonosis, and we see many infections in children that are zoonoses, and this is a good example of that. I'll talk a bit more about its epidemiology and its clinical features, and the way we can diagnose it, and when we need to think about it, and how we can treat it. All right. So leptospirosis is a spirochete. I mean, we're more used to dealing with the spirochete treponema pallidum in syphilis, but leptospirosis is a similar spirochete. We make the diagnosis of syphilis a lot, and we make the diagnosis of leptospirosis rarely. And similarly, we make the diagnosis of Borrelia very rarely as well. But Borrelia is another infection. Borrelia burgdorferi is another infection that can occur in children, and but we rarely make that diagnosis. But today we're talking about leptospirosis. It's a very diverse pathogen. This is what it looks like crinkle cut chips or these spirochetes. It's but it is diverse. It's diverse in its serovars or like serotypes, variations, genetic variations of the spirochete, and there is some diversity in terms of its clinical features, mostly the predominance of clinical features in different countries based on the different serovars, but overall the clinical features are largely the same. It is, as I said, a zoonosis, and there are many animals that can become infected with leptospirosis, and um, but the predominant ones in Pacific Island countries are rats and other rodents, rats and mice predominantly. The mechanism of that animals get infected is that they develop a chronic kidney infection. The spirochete invades into their bloodstream and gets into their kidneys, and they develop chronic kidney infection. And they excrete during their life. Rats and rodents who are infected excrete the spirochetes for life. There are some other larger animals, dogs, cattle, horses, can also become chronic carriers, or they can get infected and die. And so this mostly in most of the studies that have been done, the predominantly infected animals in Pacific Island countries, including in Papua New Guinea, are rats and mice rather than dogs and cattle and horses. It is estimated by WHO that there are 1 million cases, obviously a very rough estimate, and partly this reflects the fact that it's rarely diagnosed and often it's diagnosed as some other disease. About 1 million cases annually in the world and 60,000 deaths from leptospirosis seems a reasonable estimate. That's in adults and children, mostly, of course, in adults. But I wanted to talk about pediatric leptospirosis, partly because there have been outbreaks recently in many Pacific Island countries. The biggest outbreak in the last few years has been in Fiji. And the story of leptospirosis in Fiji goes back a long way, so long before 2012. But in 2012, there was very severe flooding throughout Fiji, and there were 576 confirmed cases reported and 40 deaths. Again, mostly in adults, but also affecting particularly adolescents, older children, but also young children as well. And then a very recent outbreak just the year before last and last year, 2003, 2023, and 2024, and which is ongoing even now, predominantly affected young adults and adolescents, especially 10 to 19 years old. In that outbreak, there's more than 1,000 adolescents and children affected, and there were several deaths among those patients. So this tells you something about leptospirosis. It's a predominantly a wet season infection, and I'll explain why that is, and especially if there's flooding. So in areas where there's flooding and a lot of rain, then you can expect leptospirosis if the other ingredients are there, including infected rodents or other animals. It is increasing in incidence throughout Fiji anyway. Compared with before 2000, cases were occurred in the 20th century. There were cases occurred and documented way back to the 1950s, but it's increasing in the last 25 years. Similarly, in other Pacific Island countries, we know that there's widespread occurrence in animals, rats, rodents, especially less commonly in dogs and pigs and other animals, but rats and rodents, widespread occurrence in animals. There's been a lot of veterinary research showing this. And there are many confirmed clinical cases from at least 13 of the 14 Pacific Island countries. So there's been studies done confirming that at least 13 have confirmed cases of clinical leptospirosis in patients in humans where the testing's available. And certainly there's been quite a bit of publicity about leptospirosis in Fiji in the last 12 months, and there's been many children and adolescents especially affected by leptospirosis. In Papua New Guinea, most of the research has been zoonotic research and microbiological research rather than clinical research. There's been some clinical research, but mostly it's been among animals. And there was some good studies done by the Institute of Medical Research that showed that among bats and rodents especially, 30 to 40% of them were colonized in the urine but with leptospirosis. Less common in cattle and dogs, relatively rare, but does occur. And in in Papua New Guinea, there have been studies of human leptospirosis, mostly exposure to the spirochete, dating back as early as the 50s and 60s. In fact, most of the clinical studies on leptospirosis in Papua New Guinea have been the 1950s, 60s, and 70s. And there were three studies in that era when they took healthy volunteers and found that more than half, 53 to 58%, depending on the study, were seropositive for leptospirosis. So it's clearly there's widespread exposure among people in those days anyway, in the 50s, 60s, and 70s. And it would be surprising if it wasn't the case now, given the increase in incidence of clinical leptospirosis in Fiji and other Pacific Island countries. So we know there's widespread environmental exposure to leptospirosis, but it is rarely diagnosed because it's not tested for, and I think also because people don't uh, quite know when to test for it or when to be aware that it might be causing a disease. As I said, in mostly in Oceania, in Pacific Island countries, it's rodents that are the primary vector, rats and mice, sometimes bats, less commonly cattle, pigs, and dogs. And as I said, they become chronically infected in their urine and they excrete in their kidneys and they excrete the spirochete in their urine throughout life. And obviously they excrete it into the soil and the spirochetes can survive in moist soil and in mud for up to 28 days, even longer, under the right temperature. If it's warm, then the spirochete can survive, and that explains why. That's partly why during the wet season and during flooding that clinical leptospirosis becomes a major problem. Humans get infected by either direct animal contact. So if there's direct contact with infected animals, domestic animals or farm animals, or direct contact with rodents, or by contact with infected water or infected soil. And the common ways in which children come in contact are either bathing in infected water or or drinking infected water, or if they are walking around on dirty, muddy soil without any foot covering, any shoes, then cuts and abrasions on their skin can lead to the spirochete invading. The animal doesn't have to be present anymore because the soil or the water becomes contaminated, and as I said, the spirochete can live up to 28 days in warm, muddy soil. What happens during a flood is that floods contaminate the water supply. They lead to uh, um, disbursement of a water supply over a large area of land, and that can then get into the disbursement of like rainwater over a large area of land, and that can get into the water supply. Now that there are um, overpopulated urban settlements that may have a communal tap that comes from a common water supply, or they might get water from a river. If there's flooding, particularly, there is likely to be contamination with the spirochete. Direct sunlight will kill the spirochete, but if it's buried in muddy water or in soil or mud, then they won't be killed directly by sunlight. So even if it's very hot and sunny, then nonetheless the spirochete can still survive for about a month in that water. And it's really the contact of humans with contaminated water that is the biggest issue. The earliest, this is some history, but the earliest descriptions of what was found out to be leptospirosis later was called Veale's disease. And Veale's disease was, there was a scientist called Adolf Veale. He described adults and children becoming unwell with three features: one, jaundice; two, thrombocytopenia and hemorrhage, and especially hemorrhage into their eyes, subconjunctival hemorrhage, and acute renal failure. And those three cardinal features were enough to diagnose Veale's disease um, in the late 19th century and the first half of the 20th century. The clinical diagnosis of Veale's disease were in patients who had jaundice and thrombocytopenia and subconjunctival hemorrhages, particularly, and acute renal failure. That was Veale's disease. And then in 1915, so over 100 years ago now, it was confirmed that that was due to the spirochete. And in those days, it was considered somewhat of an occupational disease, and there were certain occupations that were most at risk. You can imagine farmers, people who work in sewers where there's flooding or overflow. Coal miners were particularly at risk because of the water that flows through coal mines, and people who are engaged in not so much fishing but fish cleaning. There was often direct contact with the spirochete from the infected water. But in those days, in the earliest descriptions of leptospirosis, children were infected, and they were considered in. They got it. They became infected when they bathed in fresh water. Of course, it's not fresh water; it's contaminated water. But that was opposed to bathing in the ocean or the sea, and bathing in fresh but contaminated water. And those who had contact with animals in the home were also considered at risk. So remember Veale's disease, because I think we see a number of children that have jaundice, thrombocytopenia, and acute renal failure, and often we imagine that it's malaria or it's sepsis or it's hemolytic uremic syndrome or some other some other infection, but some other condition, but it may well be maybe Veale's disease or leptospirosis. Since that earliest description, the clinical manifestations of leptospirosis have been much better described in children and adults. And we now know that there's a wide range of clinical features, and like all infections, can be from very mild to very severe. And the mild infections look at a bit like influenza, and they typically there's fever. Sometimes there's only fever, and sometimes there's myalgias or muscle aches and pains, rigors with fever. systemic features of headache and vomiting, eye pain, photophobia, and diarrhea. So a, a child or a patient can have anything from just a fever to more generalized systemic features that would be consistent with a very bad case of the flu. And there's what's described in leptospirosis are two phases. Um, a, it's considered a biphasic illness where you have a bacteremic phase where the spirochete is circulating in the bloodstream, and that usually goes for about 7 to 10 days, and that's followed by an immune phase from about a week from the onset over the next couple of weeks. But there's much overlap, and often I think in children, it's hard to distinguish between the bacteremic phase and the immune phase because the clinical features overlap a lot, and sometimes there's not uh, a lull in between. One goes on to the other. In the immune phase, which is the patient is often not bacteremic at that stage, but has developed antibodies to the spirochete, then patients often, either because of the sepsis from leptospirosis or because of the immune changes, they may go into develop an acute kidney injury, so acute renal failure. In South America, Brazil particularly, the one of the features described is pulmonary hemorrhage. That's quite common in critically ill children in South America with leptospirosis. In India, what's described is myocarditis. So again, an inflammation of the heart muscle, and to some extent, this relates to different serovars causing different manifestations. But overall, kidney failure, shock, liver failure is quite rare, even though jaundice is common. So not that many children go into liver failure, but many children get jaundice. And then an aseptic meningitis can occur in somewhere between just over a half of all patients with the in the immune phase of leptospirosis. So that's half of all children that become seriously or critically ill. So those features, remember the bacteremic phase, which looks a lot like influenza, and then an immune phase that where organ dysfunction is quite common. There's some um, the spirochete is obviously alive in the bloodstream, and it's highly motile. It penetrates the liver and the kidneys, the lungs and the brain and the eyes, and it sets up a vasculitis, inflammation of blood vessels. And this is I thought this was quite good. It's from Histopathology India, and it describes the animals that are commonly infected by leptospirosis. It describes how humans can get infected, contact with urine, rodent urine or other animal urine, sometimes other body fluids from infected animals like saliva, and but more commonly contact with water or soil or food contaminated by the urine of infected animals. And it describes the clinical manifestations of leptospirosis. We've talked about aseptic meningitis, sometimes respiratory disease, particularly pulmonary hemorrhage, sometimes liver dysfunction, but very commonly jaundice, and quite often acute kidney injury. And the mechanism of getting infected is often skin broken or a cut or scratch, broken skin or a cut or scratch, or drinking contaminated water. So in Southeast Asia, in India particularly, it's it's been reported that leptospirosis causes 13% of non-malarial fever. That is, if a child's got fever but they don't have malaria, then 13% of them will have leptospirosis. And it's also described in India as frequently the cause of infections that look like dengue but are negative. So if you've got a patient who's seronegative for dengue, and you can't find any other cause, then think of leptospirosis if their clinical features fit that. I mentioned about the subconjunctival hemorrhages before, and this is common as a clinical manifestation of the hemorrhage that children get and the thrombocytopenia. And these are children who've got subconjunctival hemorrhages related to leptospirosis. They can also, apart from the conjunctival hemorrhages, they can get retinal hemorrhages as well, and inflammation of the optic nerve and optic neuritis. So there's a lot of eye manifestations. Remember, I said it's like a vasculitis of the eye, and that coupled with thrombocytopenia, which is very common, can lead to these conjunctival hemorrhages. Quite a characteristic feature of leptospirosis. So if you see that in a jaundice patient, then consider leptospirosis. The best clinical descriptions in pediatrics have come from India and Brazil and Turkey. And I think these two papers from India provide the best descriptions. And when you combine them, fever occurs in almost all children. Many children have headache and myalgia, so a quarter of all children. Jaundice only occurred in 17%, but most children had hepatomegaly. 9% had shock and 7% had meningitis. So a little bit different to the descriptions of adult leptospirosis, but I think just know the types of clinical features that can occur, and that they may differ depending on the severity of illness of the child, depending on the age of the child, and depending on where the child presents, where they're from, and the serovar they're infected with. In Brazil, again, as I said, different serovars of leptospirosis, and they were much more likely to have jaundice and renal failure and thrombocytopenia and pulmonary hemorrhage. Was rare, but did occur. But many children had a pneumonia, appearance of pneumonia with respiratory failure. In Brazil, they traced the leptospirosis back in 88% of cases to contaminated water. And this is important, again, when to think of leptospirosis when a child's had contact with contaminated water, particularly during the wet season, and especially if there's floods. They pointed out, even for these children, if there are even if they're critically ill, these were children admitted to an intensive care unit. There is a good response to standard antibiotics, but only if the infection is treated early, and you avoid the organ failure aspects of it. Avoid a severe acute kidney injury, and avoid liver failure. The differential diagnosis of leptospirosis is important because there are all the other infections that we typically diagnose when a child has a systemic infection that looks a bit like malaria, or looks a bit like influenza, or looks like typhoid. Um, and so these are the ones that are most commonly not mistaken for, but like in the differential diagnosis of leptospirosis, and they are malaria and typhoid and dengue. And dengue is important because the outbreaks occur in similar weather to leptospirosis. When there's a wet season, when there's flooding, then dengue is a bit more common, and yet the clinical features can look rather similar. We see a lot of children with staph toxic shock syndrome or staphylococcal sepsis, and they can look a bit like children with leptospirosis as well. And viral hepatitis, because of the predominance of jaundice and in these patients with leptospirosis, can also manifest as looking like a hepatitis picture. And then there's rickettsial disease, which we've talked about previously. Typhus, scrub typhus, is relatively common in Papua New Guinea, or at least it was common in the 60s and 70s when it was mostly being studied. But often, again, like leptospirosis, not commonly diagnosed in children. Again, the clue to diagnosis is the exposure to contaminated water, especially during floods. And there's plenty of opportunities in Papua New Guinea, just like in Fiji, for that sort of environment, that climatic changes, those climatic circumstances to occur each year. The diagnosis is made based on clinical features, and as I said, Vail's disease was initially diagnosed for many decades based on clinical features, but there are other ways to diagnose it that are more precise. And these days, if a patient's in the bacteremic phase in that first week, then polymerase chain reaction can identify leptospira DNA. Traditionally there was a mechanism called dark field microscopy, which involves using a condenser on a standard microscope, a special condenser that directs the light in a tangential way, and when the light is directed in a tangential way, then the spirochete bacteria show up as bright, these bright spirally structures, these motile spirally structures against a dark background. So that's dark field microscopy. It's not hard to learn how to do dark field microscopy, but you do need a, a proper condenser. And sometimes this can show up in plasma, but often it shows up in culture. It's a way of identifying the isolate on cultured medium. But these days, a PCR for during the bacteremic phase, and then during that second phase, that immune phase, then IgM rises. As we know, IgG represents usually previous exposure, so that 50% of people in healthy volunteers in Papua New Guinea that were seropositive, they had IgG, but an IgM suggests that there's been a recent infection. And usually after 1 week of the bacteremic phase, then IgM will be produced, and then comes the immune phase. And there are rapid test kits that combine the testing for IgM and IgG combined, and they can confirm the diagnosis of leptospirosis if IgM is high or IgG and IgM are elevated. Um, that's the way the diagnosis is commonly made. Certainly in Fiji in the recent outbreak, that's the way the children were diagnosed, by a positive IgM test. It's even more convincing if the IgM is rising after the second week, but you're really trying to diagnose it in the first week or the early in the second week when the patient's starting to deteriorate in terms of progression from flu-like illness to something more serious. There are, of course, apart from the specific diagnoses for leptospirosis, there should be a general investigation for children who are systemically sick with what looks like a sepsis-like illness. Certainly in leptospirosis, in a full blood count, you can usually see neutrophilia, sometimes neutropenia. Often you see thrombocytopenia, and invariably also you see lymphopenia. So the lymphocyte count is low, the platelet count is low. Usually the neutrophil count is high, but not always. Liver function tests, again, as I said, jaundice is common, but liver failure is not that common. So what you typically see is the bilirubin will be high, but the ALT and the AST might just be a little bit high or a bit abnormal, but not to the point of um, um, signifying liver failure. That's quite rare and usually occurs in sort of an end stage process. But jaundice is very common. Creatininuria, because acute kidney injury of some sort is quite common in these patients, either because of the sepsis from bacteremia or because of the immune phase, where there's immune complexes affecting the kidney. It's common, just like in many forms of sepsis, to see children with leptospirosis who have hyponatremia. So again, important to just measure electrolytes and look at the serum sodium. Urine microscopy can sometimes see spirochetes. A blood culture should be done, and sometimes when you can see spirochetes through dark field microscopy, or a blood culture looking for other pathogens. And don't forget, there are some, certainly in dengue outbreaks, there have been children who've had co-infection between dengue and leptospirosis, and also with malaria and leptospirosis. So just consider it if you've got a child who's got atypical features for malaria, for example. If a child's hypoxic or they've got any respiratory signs, then they should have a chest X-ray. And some studies have looked at the CSF in children with leptospirosis, because more than half of all children with severe lepto will develop aseptic meningitis. You shouldn't do a lumbar puncture if the patient's thrombocytopenic, and if they've got conjunctival hemorrhages, you certainly shouldn't do it until you know do their platelet counts within the normal range. But typically what you see is an elevated protein, not very elevated like in tuberculosis, but a bit elevated. The glucose is normal, but you see the features of aseptic meningitis, this pleocytosis, which just means high lymphocytes or neutrophils, but typically lymphocytes, and just the features of aseptic meningitis. It's meningitis, but you don't grow any bacteria, you don't find any other pathogens. So again, in a child who's got a febrile encephalopathy, then think about leptospirosis, just the same as we think about typhoid and we think about meningitis and encephalitis, etc. The treatment, the good thing about leptospirosis, a bit like syphilis, is that the treatment is pretty straightforward, and it hasn't changed that much in the last 50 years or more, where other pathogens have become resistant to commonly used antibiotics. Leptospirosis is, like syphilis, has largely maintained susceptibility to benzoyl penicillin. But if you've got a child who's quite unwell, then you might want to start with a broader spectrum antibiotics like ceftriaxone. That too will cover leptospirosis. So you've got it covered if you're giving a broader spectrum antibiotic. For many, in some places where both rickettsial disease and leptospirosis is common, then doxycycline is used, but shouldn't be used in young children. Very important not to use it in young children because of the effect on teeth, on dentition and enamel formation in teeth, as well as antibiotics. So get the antibiotics right and start them early. But as well as that, then children with severe leptospirosis, just like all critically ill children, need supportive care, and they need support for any organs that are affected. Simply oxygen if they're hypoxic, fluids if they're dehydrated or shocked, or even inotropic support occasionally, renal replacement therapy if needed. Bring the fever down, but don't give paracetamol to these patients because of the risk to their liver. If a patient's jaundice, it's much better not to give paracetamol. And if the child is bleeding from their thrombocytopenia, then the thrombocytopenia should be corrected. Or if it's under 20,000, the child runs the risk of bleeding, so the platelet count should be supported. As I said, if they've got an acute kidney injury, then renal support, dialysis is important, or managing a child's fluids until they can recover from this. In the sort of earlier series of children and adults with leptospirosis, a big risk factor for death is renal failure, but that's mostly because children didn't get any particular support for their acute kidney injury, and now that that's available and the outcomes are much better. Some people for severe disease, especially for lung disease in adults, they give steroids for severe disease. And there is the concept, which was a concept that's important to understand, called the Jarisch-Herxheimer reaction, that was initially described in relation to syphilis treatment when penicillin was first given to patients with syphilis. There was then this, for the next 24 or 48 hours, usually about 24 hours, a hyperinflammatory response where patients would get fever and rigors and chills and myalgia and all the features of hyperinflammation. And that occurred because of the rapid lysis of spirochetes and the release of the sort of toxins from the dead spirochetes, and the stimulation of the immune system that occurs because of that. It's called the Herxheimer reaction, or the Jarisch-Herxheimer reaction, from a couple of German dermatologists who described this to begin with. But that's another reason why steroids are often given for severe leptospirosis. So I think it's useful to do that to dampen down that reaction if you've got a patient who's got a severe multi-system leptospirosis infection. And recently we've had some success in doing that in patients with a sort of immune form of encephalitis related to leptospirosis, the immune form in Fiji. There is of course, public health measures that should be in place, and this relates to what I said at the start about One, the vectors, the animals that are most infected, and the whole concept of One Health, that for many infections, unless you address the veterinary aspects, the environmental aspects, then we'll never really get on top of these things. Certainly, the basic things that can be done, like control of rats and mice in homes and around properties, and you can do that in many ways. Um, education for communities about eliminating a rat's food source, so secure garbage, don't leave food around, don't allow rats to get at garbage and chew through plastic bags and reach the food. Pick up fallen fruit and nuts, even certainly fallen fruit. If there's fruit around the house, fallen on the ground and squashed, then rats will get at it. Fence off if you can vegetable gardens to allow rats not to be able to uh, um, it won't attract the rats, but especially certain food sources, rotten fruit, meat, that sort of thing, that always attracts the rats. And when you get rats, then you are likely to get infected rats, and you therefore get leptospirosis because they pass urine. You also get snakes. If you've got rats, you get snakes, and so it's very important for rodent, the environmental health of a village, of a community, does. It's important that rats don't uh, yeah, they're not around. Children should avoid exposure to contaminated or stagnant water, especially during a flood or a rainy season, and especially if they've got, well, trying to get kids to wear like something on their feet when they're walking across a field is important. If you're walking on flooded ground or on wet ground with bare feet, then and you've got any cuts or abrasions, then you're quite likely to get whatever's in the soil, and it might be leptospirosis or it might be some helminths we've talked about before. Um, Obviously, care with bathing and drinking water for children is vital, and fencing off farm animals away from houses is also important. Even though I said that farm animals typically are less colonized with leptospirosis, it's the contact you can have with a farm animal or contact with the farm animal's urine that can increase the risk of leptospirosis as well. So, look, the key points again, don't want to overstate the importance of leptospirosis beyond, it's not as important as malaria or HIV or those infections, but we should think of leptospirosis, especially in certain circumstances. If there's a flood or in the wet season, think of it. In a child exposed to contaminated water, think of it. In a child with fever and subconjunctival hemorrhages, like I showed you, we should think of it. Or if they've got fever and generalized sepsis, or fever and flu-like illness, or fever and jaundice and conjunctival hemorrhages, then certainly think of it. And if you see a patient who's got a biphasic febrile illness, they're unwell for a week and then they have a deterioration at about 1 week with a aseptic meningitis or encephalitis, then also think of it. I think there's plenty of children that are exposed to these environmental conditions that we probably should be making the diagnosis of leptospirosis a bit more commonly than what we do. Remember, the differential diagnosis is broad. It's not just obviously typhoid is more common, malaria is more common, or at least we're making those diagnoses more commonly. But also, I think there's a smaller proportion of children that will have leptospirosis, and we need to think about it in the right circumstances. Remember, I said antibiotics early. It's highly effective, and if patients remember, it's a highly sensitive spirochete, so giving penicillin or ceftriaxone early is good, and that all children with sepsis, leptospirosis is a form of sepsis. All children need supportive care, including in lepto, the control of hemorrhage. That's very important, and the prevention of thrombocytopenia where possible, just like in dengue. Okay, well, that's all I want to say about leptospirosis. So I hope, as I say, it's been an example of One Health, of a zoonosis, of a emerging infection in Oceania, something that is real and is more common. And I think with climate change and urbanization, and then it's likely to be even more common. So I'm going to stop the recording, and happy to answer any questions that you might have or not. Thanks.